Dear colleague, dear friends, it's a great pleasure and a great honor to welcome you to this EHAT interviews. We have an exceptional guest today with Professor Mannucci. Professor Mannucci, very nice to have you today with us.
Thank you, Cedric.
Professor Mannucci, I would like to start with a little introduction. You have been one of the key figures, but also one of the major witnesses to the extraordinary evolution of hemophilia care over the past 5 decades. You encapsulated recently these 50 years of evolution and revolution in a remarkable article that was published a few months ago in GTH. And I propose that we together journey through the distant and recent past, linger in the present, and then turn our gaze towards the future. Through this discussion, I hope that our senior colleagues attending this interview will remember, and that the younger generation will gain a much deeper understanding and vision of the challenges and the success that they've marked these 50 years of hemophilia care, certainly guided by one of the most brilliant and prolific experts of the last century and the present century, which is you. So, Professor Mannucci, let's turn back to the past and your encounter with Judith Pool and her discovery of the cryoprecipitation technique. What was the impact of this discovery? If I'm correct, you were there, and the development of the first factor concentrate in the 70s.
Well, it was the start of modern hemophilia care in the late 60s, because previously only blood and plasma were available, and you can imagine that they were not useful to stop bleeding. Cryo, at least, was concentrated, so it could be infused in relatively small amount without impinging on the blood volume. But really, the step forward occurred in the 70s, when using basically the discovery of cryo as a weapon, the pharmaceutical company produced a number of concentrates whereby factor 8 and factor 9 could be injected not by drip like cryoprecipitation, but by simple intravenous infusion. And that was a major step forward. It was called by the lay press the success story of the decade, because it did allow home treatment, it did allow self-treatment by patients, could infuse themselves by themselves for their patients, and also it allowed the first initiation of prophylaxis, that is, the prevention of bleeding instead of the treatment of bleeding. So that was really a big step forward in the 70s.
And do you think that Judith Pool at that time anticipated the major advances that she achieved with this, the discovery of this principle? You were there at that time.
Well, I can only tell that she was a very nice lady, very pleasant, and even though she was on sabbatical, so she wanted to enjoy the advantage of being in Oxford. She was there with her husband. She was very prepared to teach me patiently how to prepare cryoprecipitation, which I used when I went back. I'm not a blood banker, but when I went back to Italy, I was able to implement it with the help of the blood bank. So she was aware of the big step forward, but probably also of the development that took place depending on his basic discovery, that factor 8 is concentrated by cryoprecipitate of human plasma.
Sure. And now let's now move to another period that you nicely describe in your paper. So let's now move to the period from the 80s to the 90s. So what would stand out in your memory regarding this 1890s?
Well, that's, I could define a period of shadows and light, because the shadows are that at that time it becomes evident that these very useful concentrate were transmitting dreadful diseases, blood-borne diseases such as HIV and hepatitis. But the let us say, the lights were that the tragedy of AIDS and hepatitis did trigger, in my opinion, the development of techniques, particularly by Ed Todden and others, that led to the cloning of the gene for factor 8 and 9, which were the basis for the production at the end of the decade of recombinant factor 8 and recombinant factor 9. It changed dramatically the picture and also the life expectancy of this patient. That I want to remind that in the 60s was no more than 20, 30, maximum 40 years. And in this period, it became a little bit longer, that is closer to 60, 70 years. So that was a decade of lights and shadow, I tend to repeat.
And then let's describe and focus on the next period from 2000 to 2010. It's not so far from today. And you call this a consolidation phase. So could you a little bit elaborate about this? Why do you name this a consolidation period?
Well, recombinant factors became available, and also plasma-derived factors were safer. And so there was an extension of a regimen of prophylaxis, which beforehand was not used universally. And in that decade, a very important step forward was the demonstration by an article, a randomized article published in the New England Journal of Medicine by Manco Johnson and others, that prophylaxis is superior to on-demand treatment, that is treatment only of the occasional bleeding episode to prevent bleeding and to avoid arthropathy and the damage to the joints, which is the hallmark of hemophilia therapy. There were also other advantages, but these were the main advantages. So that I think it was an important decade. But certainly there were some attempts to get rid of HIV, certainly very important because it was shown that heating the lyophilized concentrate could avoid the transmission of HIV. I remember when I went to Paris and I met Montagnier, with whom we then published a study in The Lancet showing that heat-treated concentrate were not transmitting HIV. They could unfortunately transmit hepatitis. But then a next big step forward in the same decade was the demonstration that the use of solvent detergent was able to inactivate also the hepatitis virus. So it was really a decade with a lot of progress.
And when, while reading your paper, well, clearly you could not hide your major enthusiasm for the period 2010-2020 with a major therapeutic revolution, especially for the treatment of Hep C, and also new treatment by two extraordinary researchers. And in several papers, you have clearly emphasized their major contribution to the field of hemophilia. Certainly Glenn Pierce, known by most of us, and also on the other side of the planet, Midori Shima. And they really made major contributions. So certainly in terms of producing no factor 8 and new treatment approaches. So could you elaborate a little bit on the value of extended half-life factor 8 and factor 9? Certainly Glenn Pierce played a key role in developing them.
Yes, you're right. He played a key role in developing the first type of extended half-life factor 8 and factor 9. So that's why he is mentioned as truly a pioneer. You know that whereas for factor 9, there was a substantial change in the number of infusions that were needed to prevent bleeding, that as instead of let us say 2 per week, definitely 1 per week, if not 1 every 10 days or fortnight. The situation was not so brilliant for factor 8, that for which the reduction of the infusion was less dramatic. And you know that was due to the fact that the half-life of factor 8 was dependent from that of available factor. And so the extended half-life were an advantage because they allowed infusion let us say, at least twice a week, twice, thrice a week, instead of every other day, but certainly not as favorable as hemophilia B. And more recent progress has been able, as we will see later on, to overcome this problem of the ceiling effect induced by von Willebrand factor on the half-life of factor VIII, and so on the first generation extended half-life products.
And another major advance will certainly be the development of a bispecific antibody. This is so bright, so bright to think about, the potential of this bispecific. And clearly, a pioneer here was Midori Shima. So that has clearly revolutionized the treatment. But people still see strengths, but also some weaknesses in this new agent, this bispecific antibody mimicking factor VIII. What's your view, considering your long-standing experience in the field? How do you see this treatment innovation?
Well, listen, the fact of moving from intravenous injection to subcutaneous injection obviously is a big step forward. Probably I would list as a second big step forward the fact that patients with factor VIII inhibitors that could not be treated easily, at least in terms of regular prophylaxis, could be put in regular prophylaxis as much as easily and effectively as they appears without inhibitor. So these are the main advantages of emicizumab, which of course is a fantastic drug, mainly for the reason that I mentioned, but also of course for patients without inhibitors. It was a true advantage, and the drug is becoming more and more widely used. I can foresee, for instance, that it make possible, although not at the moment feasible, treatment also in countries where a hemophilia center are very far away from the actual patients, because of course patient can do self-treatment and whole treatment much more easily than by means of an intravenous infusion. So these are the cons. There are many cons. The pros. Cons are that there are still lack of demonstration of superiority versus factor VIII concept, apart from the route of administration. The fact that being discovered in the last few years, there's still not a very long-term evaluation in real life, even though, of course, this is progressively improving. And also the fact that we don't know yet whether the prophylaxis with emicizumab is able to prevent the damage of hemophilic arthropathy. Also, we are lacking direct comparison with the infusion, but and also plus I would say the fact that zero bleeding, that is no bleeding at all in the frame of prophylaxis, has not been achieved with this product also, in spite of the fact that probably the percentage of patients with zero bleeding increase in comparison with the first generation of extended half-life factor VIII. The problem of thrombosis had been, of course, thrombosis, at least theoretically, may be related to the fact that there is no natural regulator of the activity of this product. And also there is not the peak and trough of factor VIII that, of course, are not advantageous from the point of view of hemostasis, but are advantageous from avoiding a stable state of coagulation that might facilitate the risk of thrombosis. But notwithstanding the fact that in the pivotal study, there were a number of thrombotic episodes, which are usually unusual in the pivotal study when patients are highly selective, and so rare side effects are not easily encountered. This was really something that was worrisome. However, I must say that now the drug has been used by several thousand of patients throughout the world. So this risk of thrombosis has been, in my opinion, reduced. Even though personally I believe that older patient, a patient high risk of thromboembolic disease or who had thromboembolic disease should not use this drug because they are by definition a very high risk of thrombosis. But that is a personal opinion that some of the listener may not share.
Yes, thank you. Well, you already answered the next question, which was about the risk of thrombosis. And I wanted to know whether you were more concerned or reassured. Well, I can understand that you remain highly vigilant. We need to remain vigilant. Yes. And then, well, let's now address a new and key innovation in our field, which is gene therapy. So we won't have time to go into details of gene therapy. And we know that, well, clearly major advances have been achieved for hemophilia A as well as hemophilia B. There are some differences, but clearly, I think the recent science showed us that it's possible to do that. So I'm always comparing to this traveling to the moon. So we can go to the moon. Human being can do that, but it's not possible. We won't spend, all of us, our holiday on the moon. But what about you? What's your current perception of gene therapy and its future? Enthusiasm? Less enthusiasm?
Let us say, Cedric, that first of all, we have to consider that both the hemophilia enjoy, as we did discuss, an excellent treatment. So this must be considered for new therapy. And I would say that the main problem at the moment for gene therapy, really the problem number one is the fact that it can be given to children, it can be given only to adolescents and adults. And this, of course, is a major mishap in a genetic disease because, of course, children, infants that can be treated with emicizumab, by the way, are, of course, the target of a curative therapy as it is gene therapy. That is my main problem. The remaining problem are that particularly that we cannot predict easily the response to both the treatment for hemophilia A and B, and that it has been shown quite clearly for both that in some instances, let us say rare instances, patients get very high level of the factor, which may be dangerous, and others do not respond poorly and not at all. So the fact that the variability of response is a problem. The other problem, of course, the gigantic problem is the cost. Because the cost that being mentioned is not affordable by the majority of the healthcare system that exists, at least in Europe. As you know, a few patients, probably 3 or 4, to my knowledge, I'm sure the number is increasing all the time, have been treated, 1 in Germany and 3 in the United States. Certainly, I can see this is a problem in country with a national health service like my country and other European countries. But certainly, I can envisage that there will be an improvement. The side effects due to liver damage are probably going to be controlled by decreasing the dosage of the vector or by changing the quality of the vector. So on the whole, I am enthusiastic. But certainly, I cannot forget that we have an excellent treatment. This is emicizumab as much as the very extended half-life factor 8 that I'm sure you want to briefly discuss.
Yeah, and let's now go back to also very promising innovations, among which, this completely modified factor 8, some people name it ultra-long factor 8, so which is significantly modified that allows to normalize coagulation for a few days out of 7. So how do you see that drug, this ultra-long factor 8, as a major advance too?
First of all, I think that the production of this ultra-extended half-life factor 8 is a monument to molecular engineering because they managed they managed to add to the molecule factor that extend the half-life, and these were known, but also a piece of factor 9 of a Wilhelm factor that is the one that allows the half-life of factor A to be independent of the sealing role exerted by von Willebrand factor. So that I was impressed when I first read, I was the reviewer of the first phase 1 study in the New England, and the writer commented that was very enthusiastic. Now we are in phase 3, and the results are confirming this highly engineered molecule is not increasing the risk of inhibitor, at least in previously treated patient. Previously untreated patient is another matter, but there are some people that suggest that may be less antigenic, even though it remains to be shown. So it is a great product, particularly it puts hemophilia A, those who want to continue to use factor VIII and who are prepared to continue with infusion in the same situation of factor IX with the early extended half-life factor IX product. That is the possibility to infuse it for once a weekly, if not every 10 days or every fortnight. So it is a major advantage. The product is not yet licensed in Europe, but is licensed in the United States. Hopefully it will come. And okay, so the people will have another choice to make dependent on the individual feature of the patient, and particularly, of course, for the children. But children can also, and infants can also use emicizumab. We should not forget.
Sure. Well, thank you. We still have a few minutes, and maybe we need now to cover another categories of class of agents that we have not yet addressed, which are the rebalancing agents. So here the strategy is totally different. The purpose is to generate more thrombin by decreasing the activity of the physiological inhibitors, antithrombin, TFPI, activated protein C. So clearly a lot of research is going on in that area. So what's your view on this? Because some people are quite enthusiastic, some have a little bit of concerns. How do you see how this drug will position themselves in the future in this wide environmental new landscape of treatment?
Well, certainly is a new approach to treatment, that of rebalancing by quenching the anticoagulant activity of the natural occurring inhibitor. That is certainly a huge step forward. There are several possibilities of inhibiting antithrombin, tissue factor pathway inhibitor, and activated protein C. I was concerned, like many of us, to begin with, that in the pivotal trial, there were several episodes of thrombosis. But the same thing is the situation is not different from that of emicizumab at the beginning. So the jury is still out, and when we have more case material and more products, now they are not licensed, perhaps we will come to the same conclusion that it was just bad luck. My only problem is the fact that they are not licensed, so I can only express my view, and also not so much the fact of thrombosis risk, but the fact that it is not clear to me which advantage they have compared to emicizumab and the ultra-extended half-life factor VIII, and also the first generation of a standard factor IX product. Because, of course, some of them can be given once a month, which is an advantage. They can be given for hemophilia B and also for other coagulation disorder, which is not the case of emicizumab, and that can only be given to patients with factor A. So I can see an advantage for factor IX, for hemophilia B, also for rare coagulation disorders. But let us say once a month is an advantage, but not all can be given once monthly. Some can be given every day, subcutaneously, and this is pleasant. Other every week. So let us say that I still, first of all, Cedric, as you know, these are not yet licensed, so we haven't got experience. And again, the pivotal clinical trial patients are highly selected, and so they cannot really reproduce the situation occurring in real life, in real world, as we have seen and we have learned for emicizumab. And again, the jury is still out. That is my short statement.
So thank you. Thank you for summarizing these 50 years of a major revolution. So maybe a last question. What are, certainly for our younger colleagues, what are the challenges in your view, the few challenges for the years to come?
The few challenges are that, first of all, that the majority of people in the world, in the low-income countries, but also in middle-income countries, do not have achieved the progress that we have achieved in Western countries. So that this is the main message. There are still many unsolved problems. I would like to see a direct comparison of the different products as we have done in the randomized comparison between recombinant and plasma-derived factors. But of course, this is probably wishful thinking because it will never occur. There is still looming large the issue of prevention of inhibitors, because inhibitors can now be controlled. You can get rid of them through immune tolerance, and of course, prophylaxis is feasible, amicizumab, but it's still a complication that affects 1 in 3, if not 1 in 4, is a patient with hemophilia. And so that is still a major issue for research. So there are still many unmet needs, including the goal of zero bleeding, which can probably be obtained through gene therapy, but at the moment, not yet. So I hope that young people are stimulated to continue to dedicate themselves to this fascinating field, to the fascinating associated field of thrombosis or hemostasis and thrombosis, and that we can still see enthusiasm in this field, plus the big problem which I put as first of the developing of low-income countries, where the situation is certainly much less brilliant than it is in Western countries.
Well, thank you. Well, Pierre, it has been a great pleasure, great opportunity, great honor that you could share with us your very long-standing experience in the field, your insight, your never-ending enthusiasm, your dedication to our field. So that was great. So I hope, and your inspiration, constant inspiration. So I hope that you enjoyed this interview as I did, and I hope that all our colleagues who have been listening to us enjoyed it as we did, both of us. Thank you very much.
Thank you to you. It was a pleasure for me.